Welcome to this yet another molecule on oral hypoglycemic agents. What we are going to see in the next 1 hour is about sulphonylurea, one of the most used molecules, underrated we can say, but it is also having lots of controversy. So sulphonylureas, as we see, the one that we are projecting over here is the list of essential medicines as per the World Health Organization guidelines, which was given as early as 2015. As you see over here, apart from metformin, apart from insulin, the only drug which stands aside is glycoside. So these are the essential drugs as per the diabetes management is concerned, as per the World Health Organization guidelines. This is as early as 2015, as I said. So even in 2015, it is very relevant. But you see, if you see the treatment guidelines of ADA, so as we see the treatment guidelines of ADA, this is with respect to 2021, the positioning of sulphonylurea is only when the cost is a major factor, sulphonylurea comes in. The sulphonylurea doesn't come over here, the sulphonylurea doesn't come over here. ADA guideline says when cost is a constraint, the sulphonylurea comes over here. So why sulphonylurea has taken such a beating? So doesn't have the relevant evidence that we talk about the various molecules? These are all very evidence based. So does it mean the sulphonylurea doesn't have the evidence, or why should ADA underrate the positioning of sulphonylurea? That is something which we need to understand. And when we understand about all these things, we can know how to position the sulphonylurea molecules in our therapeutic management also. So briefly, we will just look into how the sulphonylurea molecule is discovered. So I'm not going to go into the details of each sulphonylurea molecules. What we are going to see is briefly like how it was discovered. So it was all way back in 1930s and 1940s when those were the years when poverty was at its peak after the World War I and World War II. The poverty was at its peak. So people were start taking rotten vegetables and meat and all. So and also the water was not so pure as it is now. So because of various contamination which was happening with these various meat products and vegetable products and the water, there were a big typhoid epidemic which was going on. So by this time only the other antibiotics also came into practice. There was one drug which was standing aside for the treatment of typhoid fever. As it mentions over here, it is 2254-RP. This was discovered by a scientist, by a physician by name Janban, who was seeing this drug, this 2254-RP, which was used in typhoid fever. This was seen in Montpellier in France. So he was noting, especially when this drug was used in typhoid fever, some of the patients developed neurological disturbances and died. Also, the chemical data, when it was done later, it revealed low values of blood sugar. So, the intravenous injection of glucose alleviated these symptoms to some extent, but in others, it was not much helpful also. So, Janban took this problem to Auguste Leboteer. So, this gentleman was the one who looked into these things. He was able to see these neurological symptoms, which was almost mimicking like a low sugar values, was discovered by Auguste Leboteer. And he was able to see similarly like people who are developing hypoglycemia when they were given insulin. So those sort of reactions were exactly happening in these people also when RP2254 drug was used. So then he said like this drug has got a potency to cause low sugar. That was the finding like Auguste Leboteer. Though it was seen by Janban, Auguste Leboteer was able to conclusively tell that it was hypoglycemia that was causing all this neurological disturbance. And beyond that, he went a step ahead and he was able to prove that this drug, he was able to prove that this action was able to seen in the total pancreatectomy done animals. This was not seen. This effect was not seen. Also, he was able to show that this was not dose dependent also. So this was observed by Auguste Leboteer, and he said this is because of the increase in the amount of insulin which is produced in an increased amount by the islets, and that is what is causing these low sugars. So this was proved by Auguste Leboteer. So he said like very categorically like the drug which is causing low sugar and it is able to produce an increase in the amount of insulin. So all this conclusion were derived by Laboratius. So with this, they were able to take forward and bring out other molecules. So the concept like how sulphonylureas came into picture are all about by this two gentlemen. One is Janban, who was able to see the reaction, and the second is by the Laboratius. He was able to conclude, yes, it is all because of the increase in the insulin and the low sugar, which was brought about by these molecules in a very categorical way. So once it has been done, there were lots of evolution in the molecules, and whereby we were able to produce other molecules also. So the molecules which are commercially available in those generation were, as it is shown over here, these are the first generation molecule, and there are second generation molecules are the one which we use right now in clinical practice. Still we have glibenclamide in practice, glipizide, gliclazide and glimepiride. These are called as the second generation molecule. Some people go ahead and say that gliclazide and glimepiride, for various reasons, they belong to the third generation. So we have these as the molecules, and this belongs to the second generation. So some of the authors claim that these two drugs belongs to second generation, and the next two, gliclazide and glimepiride, belong to the third generation. Okay, so this is how the classification of sulphonylurea is done, and the discovery of these molecules, they are no more in practice. We don't use any of these drugs into practice.